Hi everyone, a very warm welcome to all of you who are joining our webinar today, and the topic is complaints for hospital doctors. My name is Claire Sweeney and I'm joined this evening by Dr. Ed Nandasoma, who is the head of advisory services at the MDU, and by Dr. Jenna Fowler, who is one of my medical legal advisor colleagues. So we're going to spend the next hour discussing good practice in complaints management, and importantly, where you can turn for support if you are the subject of a complaint. If you look in the the webinar box on the right hand side, there's a drop down section for questions. So if you could very kindly get your questions into us, any questions relating to the subject of complaints, if you can make them as concise and as to the point as you possibly can. We're going to hope to get to a lot of those in the final section of the evening. So the plan basically is to run some slides, to do a presentation right from start to finish. Any questions that come to you as you go along, please get them in the box, and then at the end we're going to keep about 20 minutes to hopefully get a discussion going and discuss some of the stuff that's really important to you as doctors who are receiving complaints. There is a certificate of attendance. You will get that a couple of days after the webinar is finished, and you will also get a feedback request. If you could kindly fill that in, it really helps us planning future sessions. So I'm going to present the first part of the presentation. Jenna is going to help me out when it comes to responding to complaints, and then I'm going to finish it up with a few other slides. So this is basically what we're hoping to cover this evening, and some of these sections will be bigger than others. So how frequently complaints arise, the impact of complaints on doctors and on patients, why it's important to get complaints and complaint handling right, and that's a big part of what we want to get across this evening. Recognizing a complaint is not always as easy as it sounds. Responding to a complaint, that is Jenna's forte. She's going to walk us through how to do that. And then we're going to just touch on the end on meetings with complainants and on what to do if a complaint is not resolved at a local level. So complaints are stressful and they are time consuming. They're stressful for patients. Most patients are reasonable folks, and most patients are reasonably happy with the advice that they get from their clinicians. For a patient to be so unhappy that they actually go home and put pen to paper to complain about something is generally a sign that they are really unhappy and that they've taken some time out of their lives to do that. So the person who's writing the complaint is stressed by definition when they're doing it. It is most certainly stressful for those that are being complained about. And doctors tell us all the time about the personal impact that complaints have on their working life and indeed their personal lives. And the MDU did a survey a couple of years ago and asked doctors to rate the impact on their personal life, and they were really high scores. Over 30% told us that they had been very significantly personally impacted just by receiving a complaint. So you need to acknowledge that, the upset, the distress that you can experience just by getting a complaint. And it's also stressful and time consuming for people that are called upon to investigate complaints. And I know we will have a lot of senior clinicians here and people who lead teams. You will be asked to review clinical care and to contribute to complaints investigations. That itself is a huge responsibility and can be quite stressful too. So at all times, your medical defence organisation is there to support you and to help you through the managing of complaints. The reason that I've put this slide up is, if you look, the red tab in the middle is basically the NHS complaints procedures and what happens there. But if you think of a single clinical incident, and I tend to read this slide from left to right as if you'd been involved in an incident, and the one that I generally use is one that I have happened to be involved in a couple of times, and that is prescribing penicillin to a penicillin allergic patient. I've managed to write a prescription twice in my career for somebody who was already known to be allergic. Now, luckily, in both occasions, the drug was not administered in the end. But if you think of all of these situations that could arise, if the patient had taken that, you can see they would certainly complain. There could be disciplinary proceedings. My employer may say that wasn't terribly good practice. If the patient died, there could be a criminal inquiry or a coroner's inquiry, the patient could go to the GMC and say, this is one terrible doctor. So you can see that from one incident, all of these things can arise, and sometimes they actually run in parallel, which can be super stressful for the doctor who's at the middle of that error. So the reason I put this slide up was to highlight that sometimes a complaint is your very first warning shot across the bows that other things may be coming to follow. Not very often. Most complaints are just an expression of unhappiness. It's a patient wanting to know what happened and wanting an explanation. But just be aware that in the background, you know, these other things can materialize, and that's one of the main reasons that we say answering a complaint in the very best way that you can, giving it your best attention, is the best way to diffuse a situation and to prevent it escalating into other situations. So why do patients complain? I'm going to read this slide from the bottom up, actually, because I think as clinicians, it's the final one that worries us a lot. We sometimes feel that complaints are a preempt to a clinical negligence claim, that it's just a fishing expedition for some information that will then bolster a claim. But if you ask patients, genuinely lots of work has been done on this. Basically what they want is to prevent similar problems occurring in the future, either to them or to other patients. And they want to know what happened and why. They sometimes feel that they've been coming in and out of a clinical scenario without really anybody explaining what happened and what went wrong. So those are the reasons that come up time and again. What is a complaint? It is the next section, and why is it important to get it right? So the definition that I like best is actually NHS England's definition, and I've written this out with my highlighting in it. So a complaint is defined as an expression of dissatisfaction about an act, omission or decision. So it doesn't have to be something you do, it could be something you don't do, either verbal or written, and I'll come back to that, and whether justified or not, which requires a response. So the reason I've highlighted that, this notion that a complaint is justified or has merit, it comes up quite frequently when we speak with doctors on the advice line. And sometimes it's almost easier to accept a complaint when you look back and think you could have done something differently. And sometimes the very hardest complaints to respond to are the ones that you think, well, I actually didn't do anything wrong here. How on earth do I make this person happy? I don't think I could have done anything differently. So they can be quite tricky ones to, you know, for us to rationalize in our heads. The other point that I'll just pick out of that definition is either verbal or written. So verbal expressions of dissatisfaction are clearly fall into that definition of a complaint. There are provisions in the complaints regulations that if you can settle a verbal complaint within 24 hours, then that is considered settled under the provisions of the regulations. So it's a good habit to get into. If you hear unhappiness coming from patients, or they say, you know, your junior was rude to me on the ward round the other day, or colleagues, you know, are unhappy, sometimes it's really good to try and get on top of that instantly, to just say, you know, let's have a chat with the patient and see exactly what it is they're unhappy about. Could we settle this? Is it something that's easily addressed? Because that, if it isn't, that can then need to be escalated to the hospital complaints team and dealt with as a formal complaint, and a formal complaint will then end up in an investigation and a written response. So some of them can be headed off at the pass. So I think if we are alert to them, that can be helpful. And I'm going to come on later to a list of very common areas that give rise to complaints. So why is it important to get it right? There are a number of important reasons. The first is that patients deserve it. It's the right thing to do. If a patient isn't happy, even if we don't really understand why they're not happy, it's good that they get an explanation and somebody explains why. And again, I would make the point that applies whether or not you believe as a clinician that the complaint has any merit. What I will often say to doctors who have difficulty with complaints is to say, think about the last time you made a complaint. What you feel is you feel unhappiness, rage sometimes. You're full of justification and righteous indignation for your position. So that is exactly how patients feel when they complain about us. So if you get yourself into that mindset and say, right, this patient is really unhappy, I can't really explain why that is, I don't understand why, but I can certainly try and meet that head on and try and address it. And that's a really good way to think about complaints. Other reasons for that we have to get it right with complaints is because lots of people are looking over our shoulders and making sure that that happens. So the Parliamentary and Health Service Ombudsman, the PHSO, is the English Ombudsman. There's obviously the SPSO in Scotland and the PSOW in Wales and the NIPSO in Northern Ireland, but the O's all stand for Ombudsman. They're all just different flavours of Ombudsman with slightly different powers and different approaches. I like this list from the English PHSO because it applies to complaints handling generally, and you can also apply it to every complaint that you ever get. Why is it important to get it right? Again, because the GMC says we have to. As registered doctors, you must respond promptly, fully and honestly to complaints. And when the GMC says you must, then you must. So there is no way to duck out of it or say, I can't, I don't know how to. The GMC says we have to, so we will do it. The CQC will also place obligations on organisations. They're also looking at complaints handling. And one of their benchmarks is how are people's concerns and complaints listened and responded to. So that's why we have to get it right with complaints. The other reason that I would say we need to get it right is because if we get it right first time, then that can reduce the chances that the complaint will escalate elsewhere, and that is what we really do not want to happen. So when a complaint is made to your organisation, to the trust or a private organisation, your best chance to get that settled is with your very first response. What do patients complain about? We used to run a full day seminar on complaints that we did in person a number of times, and somebody used to shout out everything when the slide went up, and sometimes it feels like patients can complain about everything. But they actually, they complain about specific things, and it comes up time and again. So these are the English figures from 21-22. That's the last set of figures that we have for complaints to the NHS, and this is in England. So 225,000 complaints, about 45% of those were about community and hospital care, and about 55% are about general practice. It amounts to 618 complaints exactly every day to the NHS in England that year, so it's a huge number, and if you think of the time and effort that's involved in responding to those complaints, it's a big undertaking. There are almost 400 complaints per 100,000 head of the population that year, and if you look at the subject areas of complaints, the biggest chunk are about clinical treatment. They break down the figures in various ways. So when they look at different causes for complaints to arise, the biggest individual area is communication. And that means how we approach our patients, how we communicate with them, how they communicate with us. That is the single biggest, and that comes up time and again, is communication difficulties can often give rise to complaints. Unfortunately for us, when you break down the figures by specialty, the medical profession are most complained about, with 39% of complaints relating to us. 23.8% relate to nurses. They're the next biggest represented group. So this is a list of what we call the 7 C's, or what I call the 7 C's. I find it very useful to keep those at the front of my mind. So competence is your clinical skills, communication is how you approach and speak with patients, taking their consent, the use of chaperones, confidentiality can give rise to complaints and all sorts of medical legal peril, record keeping, and customer service is the patient's experience under your care. So all of those could be presentations all on their own, and in fact we do presentations on most of those subjects. But I think if you keep the list in mind, so if you get into a situation where you know the communication between you and a patient is not going well, and we all have consultations like that where you think the patient is not getting me and the patient is getting upset. So if, having been to the talk, you think, right, hang on a minute, that's one of the ones that they flagged up as a big source of complaints. Sometimes what you can actually do is head that complaint off at the pass. Think, right, this is not going well. Can I rescue this? Can I pull it back in some way? Could I take a break so we can both regain our composure? Could I hand over to a colleague to continue the consultation or offer a second opinion if the patient's not agreeing with what I'm saying to them? And I suppose the holy grail of complaints would be never get any complaints at all. I think that's probably unattainable for the vast majority of us, and I think most of us throughout a clinical career will have had complaints at least once. So I think just keeping that list in mind as a kind of, of things to particularly watch out for if you see them not going terribly well, and thinking about complaints that might arise as a result. Complaints in secondary care are handled differently in different organisations, and there's really a very wide variation. So patient advice and liaison services are present in most organisations, and most have complaints teams as well. But in some hospitals, they are completely combined. So the patient complains to PALS and it all goes through the PALS complaints process and comes out the other end. Sometimes they are completely separate, with the PALS team kept more as kind of advocates for the patients and the complaints team being separate. Some trusts and complaints and hospitals will centralise their complaints response unit, and some will devolve it out to different divisions or directorates. So it can be a very mixed bag, and I think trusts tend to pick what works for them. One thing I would say to the seniors here this evening is that if you think of junior doctors and trainees who are rotating through various hospitals during the training, it can be really confusing, because sometimes they've had a complaint, they kind of think they know how it works. So it can be really useful if you have juniors involved in complaints to just give them a quick thumbnail of what the actual system is. And that can be really, really helpful to them and demystifying the whole thing and diffusing it for them. Whoever writes the response to complaints are generally signed off by the chief executive of the trust or the organisation. In England, the complaints and claims can run concurrently. That's not the case in all jurisdictions. It's not the case in Northern Ireland, where I worked, where if you receive a claim, the complaint procedure will stop immediately. So there are jurisdictional variations, and obviously we will guide you on those depending on where you're situated. So I'm going to hand over to Jenna for a period, so she's going to walk you through how to respond to a complaint.
Yeah, thanks, Claire. So I'm going to cover how to respond to a complaint and then hand back to Claire for the rest of the presentation. So when thinking about how to respond to a complaint, if Claire can change the slide for me, I've got a nice illustration here. So hopefully you're not going to be responding like this, but I think this is a good slide just to demonstrate what Claire was talking about and the emotional impact that complaints can have on doctors. And one of those is understandably anger and frustration, but it's important not to put that across in the response. The response's purpose is to address the patient's feelings and concerns rather than the doctor's, so it's important to keep the response fair and balanced. So our three-step approach to writing a response. So starting your response, you should have clear sections. It's good to have a clear flow and structure to the response so that the patient can follow this easily. When you begin the response, you should start with an appropriate introduction to say why you're writing to the patient, to acknowledge it's because of a complaint. Also really helpful to identify who you are. So I am an ex-consultant who saw you on X date in clinic, so they know who this is coming from. It can also be really helpful to express empathy early on in your response to enhance the conciliatory tone. It's important to do this early on because it can set the right tone, it can be better received by the patient, and it can influence how they interpret the rest of your response. Also, as part of your introduction, you might want to offer an explanation of how you've investigated the complaint. And as an individual clinician and responding to a complaint working in a hospital, you're likely to be asked for an individual response about your own involvement. So the things that you might do to look into a complaint would be to review the medical records. You might be reviewing recordings if the patient's had a telephone consultation, or you may be talking to colleagues. And often what will happen is your individual response will be incorporated into an overall response from the PALS or the complaints team. And it can be really helpful for you to ask to see a copy of this final response before it's sent to the patient to check that you're happy with how your involvement is represented in that. And moving on to point 2, so the middle of your response. Next, it can be really helpful to go on to give a factual account of the consultation, or there might be multiple consultations depending on the nature of the complaint. In this part, you should outline when you saw the patient, why you saw them, what their symptoms were, what their examination findings were at the time. This is also a really good opportunity for you to outline your clinical thinking around your differential diagnosis, your management plan. This isn't always clear in the medical records and might not have been clear to the patient when you saw them, so it's a really good opportunity for you to explain this to the patient. The next part is a really important part of the complaint response, and this is where you respond to each point in the complaint, give your analysis of that, and it's important to cover any learning points or changes to your practice as part of this as well. In the real world, complaints are often quite difficult. They can be poorly written, quite long and complex. For the more complex cases, it can be really helpful to go through the complaint in detail, either as a printed copy or as a Word document, highlight all of the concerns, and you can then actually write them in the complaint response. And it's important to respond to all of the points and not be selective about what you respond to, even things that you may feel have less merit. It's important to do that because if you don't, there's a chance the patient's going to write back again and you're going to have to write another response, and covering all the points might also stop escalation of the complaint as well. And then the ending of your complaint response, for you as hospital doctors, a lot of this will be covered by the complaints team or PALS team. But often it can be helpful to end with a final apology for the patient's experience. The PALS team may also offer to meet with the patient. You might be asked to be part of that, and they will also give details for the Ombudsman as well, which Claire will talk about a little bit later. So how to respond to complaint. We've kind of discussed the main structure. I've mentioned apology a couple of times in there, and I know there were a few questions about that. And apologising is a really important part of the complaint response. Even if you feel nothing was done wrong at all, the patient feels that they have had a bad experience and that something's gone wrong. So apologising for that experience can show that you've heard them and isn't admitting that you've done something wrong. It's really just acknowledging their distress, and it might have taken them quite a lot to even write the complaint in the first place. When offering an apology, it's important that this comes across as sincere. Sometimes if apologies aren't well worded, they can seem insincere and might actually have the opposite effect of what we would like them to. There's a few words or phrases that can be important to avoid in an apology, such as the word if or any distress. There are a couple of things that come to mind. If we think of an example, a patient's complained, my knee operation was cancelled and I've been suffering with significant pain for 6 months because of this. What you would want to avoid is an apology such as, I'm sorry that your operation was delayed and if there was any distress because of this. So we know in this case that the patient was suffering from distress, so we should acknowledge that. Similarly, sometimes apologising for patients' feelings. So say, I'm sorry that you feel the care did not meet your expectations. This type of wording can seem a bit defensive and appear to blame the patient, so it can be useful to avoid apologising for feelings. If you feel that things could have been done better, then clearly say so and add any learning points you have. Going back to what Claire said about why people complain, they're often looking to improve the service and to stop bad things happening to other people or stop the repeat of their experience. So including these learning points can show that you've not only heard them, but you've also taken steps to learn from what they've said. And next steps can include a meeting, which Claire's going to talk about a bit later as well. And I understand that there can be, I guess, quite a lot of concern around apologies, and it can be a bit scary to offer an apology in cases of an admission of liability. I understand it's one of the myths out there. So I just wanted to clarify about the legal status of apologies. So this is taken from the Compensation Act. An apology, an offer of treatment or other redress shall not of itself amount to an admission of negligence or breach of statutory duty. So I hope this reassures you that it is okay to apologise and it is absolutely the right thing to do and can be really helpful for resolving complaints. And the next slide is an example of, I guess, a bad apology. So this is a tweet from a wheelchair user who was stuck at Heathrow on the plane for a long time after the other passengers had already been disembarked. And Heathrow replied to that. In their apology, they used the word if. And that was picked up on and criticised. So it's just an example of a bad apology that's coming up here. So we apologise unreservedly if the service Mr. Gardner received fell short of the experience and it was felt that that was insincere. Perfect. So I will hand back to Claire now.
Brilliant. Thank you, Jenna. And yeah, do you know, just when you say you were talking about when doctors are asked to contribute to a trust and overall trust response, sometimes they send beautiful long explanations of what happened to the patient, apologies for their experience. So they write a really good complaint response. Trusts have got various approaches to complaint letters or complaint responses, and a lot of them will include all of that in their overall response, but some of them don't. And I was speaking with a doctor on our advice line yesterday who had written a really good complaint response, and the trust came back to him and said the complainant has come back with further questions. And when he looked at it, he thought, well, I already answered all those questions. And what happened was they had picked out little snippets of what they had thought the patient was interested in, and that's all that went in to the overall complaint response. So that was really disappointing for him. And I think I would reiterate Jenna's point is when you're asked to contribute to a response to a complaint, ask the complaints team to let you see the overall response before it goes out to the patient, because that's your chance to kind of rectify it or say, no, I think we need a bit more on this. I think this is really important to me to get in there. So don't be afraid to ask that. And I'm sure we will have questions about complaints handling coming in. So learning from complaints as senior clinicians, I was going to subtitle this section with a quote of a doctor member of ours said to me shortly after I joined the MDU, and I quote, what he said was, I didn't do anything wrong and now you want me to go on a course. So basically that was what he took from my advice, was to say, look for some learning, try and address any learning points, change your practice and put that all into your complaint response. So obviously I had missed out some of the justification of the reasons for why that's a good idea most of the time. So I think this is my chance to remedy that deficiency in my own. So I think learning from complaints is kind of advanced complaint handling, and I think it's one that you get with experience, and as you move through your career, it can be really hard at the start to sit back and say, right, complaints are a fact of life, we are going to get them. So like most things in life, if they're annoying, irritating, even distressing, upsetting, they would benefit from hauling them out into the open, getting them into your day-to-day life, or at least, you know, your regular review, and just demystifying the whole thing. Complaints are there. There are good ways to respond and bad ways, the same as there are good ways, you know, to treat and interact with patients, and not so good ways. So I think there are lots of suggestions here for things like, you know, reviewing complaints at team meetings or educational meetings. Get your PALS team along, or the complaints team, to give you fictitious or you know, made up examples of complaints they have had and how good and bad responses have been issued. Share your own complaints with your team if you feel happy to do that. They can be completely anonymized. They don't have to name the doctor or the patient, and in fact they can be, you know, kind of woollied around the edges, so it's not a particular case. But the more we learn from these as groups of people, I think the better we get at responding to them, the less likely they are to escalate, and I think the less stress they will end up causing us. One of the concerns that when we ask doctors to reflect on complaints and add their reflections to a complaint response, it's often quite a new idea to them. But honestly, by the time that doctors have got complaints and come to us for assistance, they have done that all already. They've immediately gone back to the notes. They've looked and seen, could I have done or should I have done anything differently? They'll have gone and looked up the guidelines to check that what they did was right. And if necessary, they will have reviewed their practice and changed their practice as a result. So lots of doctors will call us and say, yes, you know, check the guidelines, and they didn't actually adhere to the news guidelines or to whatever. So, you know, I think there's a bit of a learning need there for the team. And you then say to them, well, did you think about putting that into the complaint response? And they say, oh, no, that's my reflections. But what I would say is, part of when you write a complaint response is for the complainant. You want to respond to their concerns. You also are writing it as testimony to the fact that you are a good reflective practitioner who listens to response, learns from complaints, and learns from them. So why not put your reflections in there? You've done them already. It's a really powerful way, number one, of telling the patient, I've heard you, I've acted on this, I've learned things, I've changed my practice. I mean, what more could patients ask for? But the other really nice side effect of that is if that complaint letter was ever come to be reviewed by another agency, say the complaint does escalate to the Ombudsman or even to the GMC if the patient remains unhappy, what they see is a brilliant letter with all your reflections, all your learning right in there. And you know, the impression that that gives is amazingly good, and it stands in really good stead. So I think that's one to consider. I think on general terms, I just thought I would put this slide in. I know that reflections and the recording of reflections was a cause of great concern to doctors some years back after some cases where it was thought that reflections had been used to a doctor's disadvantage. But the GMC makes it clear that they will not usually ask for responses or reflections on a clinical case. And even if they do, they won't use it to adjudicate in any way. This is really good guidance that was brought out after the Dr. Bawa-Garba case and the concerns that arose there. And basically what it says is you can reflect away, because most times you don't have to identify the patient, and therefore that would never be disclosable. You don't have to use name, age, date of birth, even the medical condition. You just pick out the bit that was difficult for you and write your reflective piece about that. So this is what the GMC says about reflective practice. You must reflect on all aspects of your professional work, and that specifically includes complaints in that list. So we have to discuss them at our appraisals. We have to reflect on them at length. So my advice would be, you're doing it anyway, put it in your complaint response, and it could stand you in very good stead if the complaint was to escalate elsewhere. The final slide in this section is just a bit of a study that was done by the GMC several years ago now. They haven't repeated it since, but basically said that doctors who can reflect and show insight on what has gone wrong for a patient, if they ever come to be heard at a fitness to practice hearing, and not very many people ever make it there, but there's a striking difference between the number of doctors who reflect on stuff and remediate any deficiencies in their performance, in that at a panel hearing, if they showed insight, 95% of those did not get erased from the register. Whereas if doctors couldn't accept that things could have been done differently and wouldn't reflect on the patient's experience, then 59% of those doctors were erased. So it's one to have in the back of your mind, and we all do reflection, as I say, share it with people and let them see that you're doing it. So the next section is on local resolution meetings. I know there are loads of questions coming in here. I'm just going to remind you that we're down to the last two sections here. So if you have any questions, please get them to us. So give us plenty to talk about in the last 20 minutes here. So I'm mentioning local resolution meetings because they can be a really useful way to address outstanding concerns once a complaint response has been issued. These are generally organised by the complaints team or PALs, and sometime in your career you may be asked to attend one of these. There is a really good learning module. I don't know if you do much CPD on the MDU website, but there's a really good learning module on local resolution meetings that I thoroughly commend to you. It's an hour long and you will learn plenty. I certainly did the first time I took it. So basically what you need to know in advance of a local resolution meeting, that is when you will sit down, or somebody from the medical team will sit down with the patient to address any outstanding medical concerns they may have, and then the trust will address any concerns about the handling of the complaint or other issues, service provision issues. So what exactly is an unresolved? Get a mutually convenient time, allow enough time, and get an appropriate venue. That's somewhere where you're not going to be interrupted repeatedly, so avoid clinical areas. You need a proper meeting room that's booked for the time of the meeting. Ask the patient to bring a supporter with them, because there's nothing worse than a patient coming into a room full of 3 or 4 trust staff and doctors and not having anybody there to support them or remind them about questions. And make sure that somebody is there to take notes, and that the patient has a copy of the minutes afterwards. In general terms, this is kind of a summary of the stuff on our website, but agree an agenda, what has to be discussed, who needs to discuss it, who's best placed to answer the outstanding questions. It may not be the doctor who is directly involved in the care, maybe that their consultant's a better fit for that. Check with the complaints team beforehand exactly how it's going to run, agree who's answering what. And very importantly, I would say look at the case in the round. And again, as a senior doctor, you're going to have the oversight of the case, and look and see if there are concerns that you can identify. Get ready to answer those concerns, even if they haven't come up before. So things that you would be worried about answering on the hoof, prepare your answers for those, have a bit of research. So the final section, I'm going to just touch on the Parliamentary and Health Service Ombudsman. As I said, this is the English Ombudsman. There are 3 other ombudsmen in the other jurisdictions in the UK. They have different powers, they have different approaches to complaints handling, but they are basically the second tier. If a complaint cannot be handled or settled directly by the trust or a private service provider, then it is referred upwards to the second tier, and they are completely independent and will start from the start and look at the complaint and how it arose. In England and in Northern Ireland, the Ombudsman can make requests for financial awards to be made if they consider that a service user has suffered an injustice. It can be done through the complaints procedures in Wales through the NHS redress system, but it is not an option in Scotland. There's no provision for financial awards there. That's just to mention the difference to you. So PHSO in England, and they all are independent of the NHS. They look at both the nuts and bolts of the complaint, so both the clinical care, but also the handling of the complaint. So if a complainant waited for 6 months to get a response, they may say that wasn't very good service, so they may mention that in the report. They can also look at complaints made by NHS staff. That's a bit unusual, but if NHS staff think they haven't been treated terribly well by the complaints process, and they can pass information to relevant professional bodies. And as I say, 2 of the 4 ombudsmen in the UK can recommend financial redress. The process is mostly done by the time we hear of it as clinicians. So can the Ombudsman investigate? Should they investigate? They can't investigate if the complainant has a different remedy open to them. So if the complainant has instituted a clinical negligence claim, the Ombudsman will not investigate that because they're already getting their answers in a different way. They won't usually investigate until the local resolution stage is complete, and that would usually involve at least the offer of a meeting to discuss things with the complainant directly. But generally, stage 3 is where you will hear this. So this is where the investigation is opened, and the Ombudsman will write to the trust and say, can we have your complaints file, and can we have any comments from the involved members of staff? And that's where you can get contacted and said, do you have any comments to make? So even if you have submitted a response to the initial complaint, you may want to formulate further response to the ongoing complaint. The Ombudsman will then gather all that information and draft up a report saying, here's what we are minded to do, here's how we're minded to settle or look at this complaint, and that is your opportunity to comment, and I would commend you to do so. It sets out what the findings are and what the recommendations are going to be, and you can go back at that stage and say, well, I don't think that's fair, or I don't think you have understood exactly this part, or I don't believe that that's correct. And sometimes you have to say that. The Ombudsman doesn't have powers to compel, you know, if they ask for a financial remedy, they can't get it out of the trust's piggy bank. But what they can do is they can escalate concerns if the trust was not to comply with their recommendations, and they certainly can lay a report before Parliament, and I suppose that's not a place where any trust wants to be. The reason that we get concerned about Ombudsman's investigations and complaints generally escalating is that if the Ombudsman's report was to criticise a doctor directly, so if it said a big part of this complaint was Dr. X who didn't seem to treat the patient as they should have been, and if that criticism was at a level where that might bring Dr. X's fitness to practice into question, the problem for that doctor is a good medical practice. Paragraph 75 says you must tell us if anywhere in the world you have been criticised by an official inquiry, and that would include some of the UK Ombudsman's inquiries. So that needs to be in the back of your mind as well. So again, it's another good reason to try and settle complaints as you go along. So we are hopefully going to bring Ed and Jenna back on screen, and we're going to start going through some of your questions, and I'm going to just plug first, if I just kind of one more minute, We run lots of courses in lots of different ways, and here are some upcoming related courses. I'm going to give a special shout out to the unconscious bias in healthcare and the managing conflict with colleagues, which are relatively new courses, but I've got really good feedback. But there's loads of stuff, and the final column is your hospital liaison managers, who will either come in, deliver learning directly to your team or to study days, or they will do it via Teams and Zoom. So please do, if you have educational needs or you want presentations, please don't hesitate to ask. So that's how you get to us. So now we're going to move to questions, I think.
Fantastic. Thanks very much, Claire and Jenna. And thank you all for both your attention and some really interesting questions here. There's some really quick questions that have been asked about process, and I promise I'll come back to those, and I'll maybe do 2 minutes at the end where we run through those. There are some sort of meatier ones that have been asked, and I want to try and give those some time. I know the first couple of questions that Jenna alluded to were questions about apologies. And the very reasonable perspective here is, look, is it absolutely necessary to say sorry when replying to a complaint, even though it's clear you've not made a mistake? And I'd just like to make a comment on that. There's two different things we're talking about. As Jenna said, and I know some of you have suggested drafts in the comments, that there's nothing wrong at all with empathizing with a patient to say, I'm really sorry that you've had this complication. You don't have to say, I did something wrong when you didn't. But the points that Jenna made here about clinical thinking and analysis is really critical when what you're trying to do is to explain why you think the management was right, and doing that with some external perspective, so referring to, say, objective guidance, so the patient isn't just accepting your reassurance, but can objectively see that what you did was correct. Is really the key to those circumstances. Where something has been done wrong and you need to apologise, then apologise effectively, you know, in the ways that was said. So that was something we touched on in the presentation. There's another one here that I wanted to sort of give Claire and Jenna an opportunity to comment on, which, because I think it's a really topical thing. Is the frustration of doctors saying that, look, you know, that sometimes these complaints are really about the resources and the capacity we have. And when we say, look, you know, we haven't got enough resources, it's the response is, look, this is what we've got, like it or lump it. How do you deal with that in a complaint? Claire, any thoughts?
Yeah, I think we hear that a lot increasingly these days, and I think it is perfectly fine to reference how stretched things are and how difficult things are when you respond to a complaint. I think it's really important that you don't let the wording become defensive, and I think that's where we can really help. So it's not saying, oh, we were so busy and it was so awful. It was just, we were doing our absolute best. We were absolutely pell-mell that night. You know, there were 3 emergencies and we were doing our very best. So I think it's a matter of not tipping over into defensive language, but it's perfectly fine to set the scene and say this was. So lots of complaint responses in the last couple of years have started off with, here's how we have to run the service because of COVID. It is totally different than it used to be, and I'm really sorry that we couldn't bring you into the, you know, to the ED immediately, but that's life in the NHS at the minute. And I think there's a big difference between being blunt and being sympathetic, and there's plenty of centre ground where we can help you with wording that will get that across exactly as you want it. Oh, Ed, you're muted, I think.
Oh, Jenna, anything to add to that?
No, I think Claire's covered all the relevant points there. And yeah, absolutely, it's something we're seeing more and more. And as an individual clinician, you're not expected to fix everything. You can only work within the environment that you're working in. So yeah, being open and honest, but putting that in a way that doesn't come across as defensive.
And I'll sort of deal with another question and add to that in the same thing, in that you know, if you're working in a hospital environment, it's perfectly reasonable for you to say to management, look, I've dealt with this complaint, but there is a concern here raised about resourcing. what's the management and the organisational response to this? That's a perfectly reasonable thing for you to say, and something they may want to take a view on. It's a slightly odd segue, but it touches on what a lot of people are sort of raising here about what about complaints relating to other people? What about complaints about my juniors in A&E and I've never seen the patient? Remember, if you're dealing with the patient, if you're dealing with the complaint, your role may be to do an investigation and put together a response based on that. And part of that is you getting an account from those people who are involved. So it isn't so much that you say to the juniors, well, you deal with this complaint. It's that, well, look, I'm dealing with the complaint. With the support of the trust, can you tell me what you say in response to this? Give me an account of what happened, and we'll deal with that. So that's another one that came up. The other question that we've got here is a couple of ones about, I think you covered about what the role of the ombudsman is. We've got a question here that says, you know, is the ombudsman the next level of the escalation process after local resolution? How is the escalation process initiated? Claire, any thoughts on that?
Yeah, it's usually done by the trust will get a feel quite early on whether a complainant is accepting what's being given to them. So sometimes the complainant will get a response and come back with more questions, and then they will get another response, and then they will say, I want a meeting. So you will get a feel that things are not going well and the patient is not accepting, and sometimes not accepting perfectly reasonable responses and perfectly reasonable explanations and very nice apologies. Because sometimes they're just unhappy with how things have turned out for them, and sometimes it's really difficult to make them happy. So at some point of the local resolution process, the trust and the patient will decide, usually together, that it has been impossible to resolve their complaint at that stage, and at that stage the patient goes to the ombudsman. The trust will provide them with the contact details they're required to do so. They go to the ombudsman and say, I'm still not happy, can you review this complaint? And that's generally how it works. And there is, I should have mentioned during the presentation, for people in independent practice or private practice, there are other second tier complaints reviewers. So there's a service called ISCAS that I think a lot of private clinics have signed up to, that they will act as a secondary reviewer of complaints. So it's just so that you're aware of that too. It's not the ombudsman unless it's NHS care.
Great, thank you. And I've got just a question here about, you know, the role of the ombudsman and whether it solely relates to issues secondary to patient-related complaints. It does, insofar as what we're talking about, the NHS complaints process. So there have been cases in the past where doctors have complained to the ombudsman if they feel badly treated in the complaints process. I would very much say talk to us before you do that, because, you know, it's not always the case that doctors will get a sympathetic hearing by the ombudsman. They don't intercede in employment disputes. There's a couple of things here that I'll put to you, Jenna, in saying, in a short-staffed service, can we see patients without a chaperone? And that follows on from that is a different question about what if a patient declines a chaperone, you know, at the start of an examination and then complains. You know, how can you protect yourself from that?
Yeah, well, I think it's important to think about what the role of the chaperone is. They're there for the patient, but they're also there for you as a doctor, to be a witness to what you're doing to prevent any potential recourse in the future if the patient has any complaint about that. So it is really important to have a chaperone if at all possible, and it should always be something that's offered to the patient. I appreciate that can be difficult with limited staff and current working environments, and there might be ways to work around that. You might want to approach colleagues at the time if you can. You might want to think about whether it's possible to defer an examination until you can have a colleague there if it's someone who's an inpatient and it's not an urgent examination that's required. So it is really important both for the patient and for protecting yourself as well.
Great, thank you, Jenna. And it is difficult because if there is a complaint and you've not had a chaperone, that still needs to be dealt with. If you kept a careful record of a chaperone being offered, the clinical reasons for the examination, what you've said to the patient about it, that's the sort of best protection. You know, We've got another sort of, we've got quite a few good ones here. So, so we've got, are there certain types of complaints the PHSO automatically reject or don't investigate? They won't tend to automatically reject, but there is lots of things that might fall out of their jurisdiction, so they won't. They do tend to have a look at those. Claire, one for you here, an old chestnut. What if the patient wants to audio record the complaints meeting?
Yes, oh, this is, it just feels so terribly threatening when the patient walks in and sits their phone down, and they do it in consultations as well sometimes. But if you think about it, all of the stuff that's being talked about at that complaint meeting is about them. So they're quite entitled to have that, and they are at least telling you that they're doing it, because I get a feeling that lots of patients record lots of things without telling their doctors. And I would almost say at this stage, and we're all walking around with highly sophisticated recording devices in our pockets, I would almost say assume that everything you say to a patient may well be being recorded. So there's no issue with that. The patient is recording their own information. They may have a bad memory, they will certainly be stressed, and they may feel that they're not going to remember everything that's said. So it's an aid memoir to them, and that should generally be agreed. It's just, I know what it feels. I know the feeling is, oh my word, it's just upping the ante here. And some patients can, you know, use it as a kind of veiled threat, but I think most of them don't. They genuinely just want a record for their own memory.
I think that's right. It's often best to say for a complaints meeting, and some organisations record the complaints meeting to say, look, share the recording, let everybody have a copy of it.
Yeah.
Though it is threatening, and I can see a question here about, you know, about surreptitious recordings. I think the important thing, or the difficult thing about these, is when this has been tested in the courts, surreptitious recordings have often been admissible in various processes, be it the GMC or the courts, when they contribute to the factual scenario. I would say a lot of the time, where it's being done by somebody unreasonable, it's actually been helpful to our members. When, you know, I remember an ombudsman's complaint where the patient had recorded it, but it was essentially a recording of them shouting at a practice manager for 10 minutes, and it was actually quite a helpful thing to have. So it is threatening, but it can cut both ways. So we've got here some questions about timelines. What's the timeline or deadline for resolution of a complaint locally and by the Ombudsman? And also, touching on that, is it, you know, can people complain many months after the complaint?
Yeah, that's a good question. So there is, the complaints regulations say, and this is England, that complaints have to be answered within a reasonable time. Now, sometimes complaints are really complex, sometimes they're really simple. So reasonable means exactly what it says. If the complainant has not had a response after 6 months, this is a kind of backstop, and they could then decide to go directly to the Ombudsman and say, and not only do I have a complaint about this trust, but also they never sent me a response to that. So the way to try and reduce the chance of that is to keep the complainant updated. If it's a really difficult complaint that you've had loads of you know, people who have to help respond, tell the complainant that, say, we're working on this, we're trying to get it together, it's going to take us a bit longer than normal. So I suppose a 6 month backstop, but it's a kind of movable feast to a certain degree. I would just say, after clinical incidents and after complaints, the GMC will look at complaints up to 5 years after a clinical incident, so that's always worth keeping in mind as well.
Great, thank you for that, Claire. Now, I promised that with 5 minutes to go, I'll do a rapid fire on a few things, and so I'll do that, and we'll come to some of the more substantive things. We've got here a comment that I've heard that somebody can complain to an MP rather than the Ombudsman. I'd say that's slightly it's slightly a different concept. An MP can be a representative that brings a complaint on behalf of a constituent. So it may well be that you get a complaint, an MP's letter, which is always a joy. You know, that because your patient has written to their MP and they're saying, look, I stand in my patient's shoes, here's their authority for me to bring it, and here's the complaint, and that is handled like a complaint in any other way.
I would say that's a first tier complaint. So that's still a local complaint, although it seems much more official, but that's not the same as an ombudsman's investigation. They're acting for their client, for their patient.
The other question here is about statutory protection for apologies in Scotland. And yes, since the apologies, I think it was the Apologies Scotland Act 2016, there is similar protection for apologies in Scotland, and in general terms, an apology to say, look, I'm sorry this happened, we'll look into the circumstances or we'll learn lessons, that probably falls under that protection. If the letter, or if something has clearly gone wrong and you say, look, this is what happened and it shouldn't have, then of course that might be relevant in any subsequent proceedings. But remember there, it's not the apology that's caused the issue, it's what's happened and the facts behind that that's caused the issue. The other thing we've got here is a question about complaints raised by colleagues, and I guess we talk about complaints in a broad sense. It can mean anything, but for the purpose of this presentation, we've been talking about complaints that fall under the regulations that deal with patient treatment complaints and are handled in a very particular way that Claire and Jenna have articulated. Obviously, if your colleagues raise complaints, then they're likely to be dealt through by other processes, local or disciplinary investigations. I would certainly suggest you get expert help at that point and contact us, you know, because those can be quite complicated and they need careful and considered a careful and considered approach. So I think those were the sort of quick things. There's another sort of interesting question here about, well, what do you do if you come to find out that a complaint's been responded to without your knowledge? You know, and you're sort of named in it. What do you think about that?
That I've had case files where that has happened, and it happens occasionally if a doctor leaves the trust where they're working and the complaint is then received. The trust sometimes thinks they just plough on. They can look at the record, somebody else can review the care, and they issue the response. And I have had doctors, when the very first time that they knew there was a complaint about their involvement was when they got a letter from the ombudsman to say it wasn't resolved at a local level, and they suddenly think, well, I wasn't asked to help respond. But I would view that, I mean, the first thing I would say is make that crystal clear to the ombudsman, so you can say the first sentence of your response will be, the first time I knew about this complaint was 2 weeks ago. Here's my response, here's all my thinking, here's my reflections, most important, and now we know why. And I'm very sorry, you know, that I wasn't previously, because I would have involved myself in that, but that's really disappointing and super stressful.
Great, thanks, Claire. We're nearly up to time. There's a couple of sort of comebacks on these in terms of complaints among staff, where we talk about complaints between people's behaviour or rudeness or bullying, etc. Those tend to be dealt with by specific dignity at work or bullying and harassment issues. There's also a comment here saying, is surreptitious recording legal since 2018 GDPR? It depends. If you're recording a phone conversation that you're party to for your own personal use, that wouldn't be a breach of GDPR. You know, further publishing of that is an issue, and we are not, as medical staff engaged in clinical care of patients, treated as third parties for the sake of that act. So there's that, and there's also a thing called the Regulation of Investigatory Powers Act that deals with surreptitious recordings when used in a wider content. So it's not legal for anybody to randomly surreptitiously record a third party, but it isn't a breach of GDPR for a patient to record their own consultation. It would get more complicated that as things move on. I think
I was just going to come in on the subject of recordings. There is a question that I should have answered at the start, and that is that this session is being recorded and it will be available for you to have a look at later. It'll be on the website. Yes, I should have.
Absolutely, and we've got a couple of things about unrealistic expectations or untrue complaints. The one thing I'd say about that is, if you get a situation where you think we're in an unreasonable complainant situation, that you've tried your best to resolve it, but you're getting, you know, really ridiculous things back, call us, talk to us. We can guide you through that situation. You still have to be calm and objective, although that's so difficult, but we're here to sort of help with that. I think we're up to time now. We've had, I think, over 500 of you this evening, so thank you so much for giving up your you know, your Tuesday evening for this. Thanks to Claire and Jenna for really excellent presentations, and thank you so much for your attention today, and we'll draw it to a close. We're sorry we didn't get to everything, but thank you for your time this evening.
Thank you.